Hello, it's Bill Paravano, the knee pain guru. Welcome to the Ask Dr. Beck show this week. Welcome, Charlie. How are you?
Other than under the weather, I'm doing good.
Yeah, well, we skipped last week. You were feeling pretty rough, and we still have the follow on from that. So,
Yeah, I'm less rough, but still not back to normal.
slightly smoothed over.
Slightly.
Hey, maybe it might be interesting to share a little bit about what you've been dealing with and then how you've been dealing with it from a physician's perspective.
You mean my illness?
Yeah.
Oh, definitely whacked in the head. That's what it feels like.
Locked in.
Whacked in the head, yes. Pretty girl. Puppy dog says hello.
Oh, hello, doggy.
So yeah, it's interesting. I'm making assumptions here, having semi gone down the rabbit hole, just looking at symptoms, that what I have going on is the new variant of the world scare that's going around, the human genetically engineered molecule that they're passing around.
Blasphemer.
Yes, right. And so what I have noticed is, having lived in my body for over 50 years, that when, for example, I get a fever, I know because there's a certain feeling in my body that equates to a fever. You feel this way, you take your temperature with a thermometer, and oh my God, you have a fever.
Right.
And there are certain things, the way the body feels when you get what's more traditionally a cold, you get upper respiratory infection or whatever it is. Well, once a year or so, I wind up getting one of those things. And so have experience of having those symptoms in my body. And what's been going on in the last week is nothing at all like that. Had a fever, didn't feel like a fever. Had a really significant respiratory infection that probably equated to pneumonia, didn't feel like pneumonia. And what I'm recognizing with this genetic engineering process is that from a physician standpoint, you got to stay on top of the symptoms. Otherwise, you are playing catch up, and that becomes scary.
Mm-hmm.
So I was way sicker than I thought I was, and I got sick really quick. And it's been challenging to try to get back in front of it to feel better.
Mm-hmm. Got it. And are there any techniques, anything that you've been doing that someone watching the show today could you do themselves, that they would need to be a physician or a doctor in order to be able to help themselves?
Wow. Not that I can think of. I mean, my wife has been treating me, which is wonderful, and has been significantly helping. But I don't know how to answer that question until I'm way on the other side of it, and I might be able to give you a perspective. So if you ask me again next week, I might be able to give you an answer. But this week, being kind of still in the middle of it, doesn't feel like it. Feels like you need a doctor to help you.
Okay, good. Cool. Well, I was mentioning to you right before we started that we're changing the format a little bit. For those that are live on the calls or on the shows, they can type in their questions on Facebook or in the YouTube live chat, and we can read those questions live. But what we're going to do, we're trying to get our SEO up a little bit, search engine optimization, so more people view the videos. So we're going to target one question per call, and we're going to use that in the title. So without further ado, we're going to dig into the question that was sent in. They write, I had a knee replacement surgery 5 weeks ago. I have full flexion and almost full extension. I am suffering from medial knee pain anytime I try to walk. I am becoming quite depressed because I should not need pain medication at this point.
Mm-hmm.
So essentially the title for this video is, how long does pain last after knee replacement?
Okay. Can you, because this is far easier for you, pull up a picture of the ligaments of the knee, please?
Certainly. 1 second. Screen. Okay. How's this one?
Let's go with the one next to it that's not labeled. No, the one to the right, that one. Yep.
Okay.
Now that's in the back, but it's going to show us what we need.
So this is the back of the left knee? Or wait.
Yeah.
Yes. No.
Back
This
of the
is
right knee.
This is the back of the right knee. Got it.
Yep.
Okay.
Okay. So basically what happens when we do a knee replacement surgery, and we're going to do full joint replacement,
Okay.
is that where your cursor is in the center, all that stuff gets cut out. Okay. It gets replaced. In theory, what they try to do is they try to save the ligaments that are on the outside. Okay. Those ligaments are called the collateral ligaments. And what they do is they prevent the knee joint from bowing too far in or bowing too far out. Right. That's their idea. So ligaments are limiters of motion. Where you see the extra bone in the back, down at the bottom, the fibula.
This right here?
Yep, that right there. That indicates the outside of the leg, so little toe side. So for what the patient is saying, they have pain on the inside. Okay. So we're going to go to the opposite side of the screen. That ligament right there is called the medial or middle collateral ligament.
Okay.
And what happens is ligaments limit motion, and ligaments in their normal state are supposed to be relaxed. So think rubber band. They're supposed to stretch, and the more that they stretch, the more that they limit motion. That's their design, and it allows us to move in what we see as smooth motion. So the more we try to move outside of a joint's range, the tighter those ligaments get to keep us from moving any further outside of that range. And so in someone who is normal, okay, everything's balanced, those ligaments are relaxed. What the person who asked the question is describing is a tightened medial collateral ligament.
Okay.
So that ligament has been traumatized from an osteopathic perspective. When a ligament is traumatized, so let's just say that you're walking along outside, it's wintertime, you slip on the ice, you fall and hit your knee on the ground. That impact is going to make those ligaments tighten. Right. You know, they may relax on their own afterwards. They may not. They may need a treatment. But what your person is suggesting is that medial collateral ligament is tightened. That tightness is what's causing the pain. Ligaments are richly innervated. They have lots of nerves and poorly vascularized. They don't have many blood vessels, so they're slow to heal. What I would suggest to that person is see if you can find someone to work with you and get that medial collateral ligament to relax, and your pain should go away almost immediately, maybe within a day.
Okay, I'm trying to make this go away here. How computers do things on their own.
Yep.
And that just did something on its own. And I am just going to quit my mail. Okay, here we go. Sorry about that.
So that's what I would do. If you came into my office, the process might take, if we're trying to do the whole knee, make sure everything's working and back in place, it might take 15 minutes. So it's not a long process. It's just a matter of taking, wish it was on my computer because I could draw. If we take there, right there where your cursor is, your mouse cursor, we take that point, okay, and we try to move that point straight down toward the bottom of the page. straight down, just like that. What we're doing is we're shortening the ligament. Okay. So what I'm going to do is basically try to bow that leg to where it bows to the outside, and the curve is to the inside. That's going to shorten that ligament.
So just so I understand this correctly, if I'm bowing this is the outside of the leg. Never mind.
Yeah,
I got you.
I'm pushing it. In this case, what I'm doing is I'm taking the knee and I'm gently pushing it to the right of our diagram.
Yeah.
stretching the outside, shortening the inside.
Yeah, there is a way. I was running one of my calls, and there was actually one of my clients actually did it for me.
Oh, good.
That knew how to draw straight onto but it doesn't seem to be the case that I have figured it out as of yet.
Yep.
So, okay, so you would be pushing
those two pieces together. Yeah, basically right where you're circling, those two pieces get pushed together.
Get pushed together, and then
those two pieces get pushed apart.
Right. Got it.
That's it.
And that's going to take the tension off of that
ligament, right? Takes maybe 60 seconds of doing that before it completely relaxes. And then once it's relaxed, unless there's more trauma, it doesn't come back.
Got it. Okay.
Yeah.
I'm going to stop sharing here and then get back to our call. So that is let's see. Should not need pain medication at this point. We would agree.
Yeah.
Pain medication is only necessary when, what is the guideline you'd go by in terms of determining if pain medication is necessary?
Well, it's interesting. The way you asked the question, I can't answer it. So I'm going to reword the question.
Okay.
So that we can understand why you would use pain medication. So what we have to do is take anatomy and physiology, and they are interrelated, but let's separate them for a moment and treat them individually. So we'll take this patient. I have had knee surgery. So surgeon, based upon their training, has gone in and used power tools to take parts of the bone out. They've used hammers or some other kind of device to drive rods into the bone. And it works, but to the body, it is trauma. Okay. Right. And that's not to say it's good or bad. It's just trauma. That trauma then causes physical changes. And what we're trying to do as surgeons is minimize the bad physical changes and maximize the good ones. We're trying to get that leg to go back to its original length that God intended. We're trying to get the joint mechanics to come back to normal, to full function. But just because we go in and we do our job as surgeons, there's going to be inflammation, swelling, pain potentially. Not everybody has it, and people have it to different degrees. But all of those things are because we changed the anatomy in the surgery. Okay. That anatomy then changes physiology. That stays till the body can heal itself. And I could make up time durations, right? But some people might heal in a week and some people might heal in a month. The trick is we're continuing to move along the continuum of healing. Every day gets better. So if we're looking at just that's the anatomy, then what happens is the pain medication continues until whatever discomfort is left, you feel like you can tolerate. Okay. And again, we're going to make it up, but let's say it takes 3 weeks. That's the average for most people. Well, all right, you'll be on pain medication for 2.5 or 3 weeks, and then you can switch over to ibuprofen or Tylenol or whatever works for you, and you might be on that for a couple of weeks, and then you're doing pretty good. Now, we have to go and look at it from a physiology standpoint. If something has changed during the knee surgery, unanticipated, we didn't know it was going to happen, but I don't know, let's just say when the surgeon uses the hammer to drive the knee into the bone, the hammer slips a little bit and hits a piece of soft tissue. Okay. It wasn't intentional, and it's not a huge deal, but something happened. We won't even call it an error. It's just, that's the way it happened.
Right.
Then what happens is you now have swollen soft tissue that is technically not a part of the surgery. That soft tissue then may not be rehabbed because we're not looking for it, right? It's not a common thing. It just happens.
Right.
And then because it's not rehabbed, because we're not looking to and addressing that soft tissue, you can have pain that goes on for much longer. 6 months, for example, instead of just 3 or 4 weeks. Because that tissue needs help. Its physiology needs to be changed back to normal. And that is where people who think slightly or majorly outside of the box can be what you need to heal. You know, we look at the body differently. We put our hands on, we let the body tell us its story. And we put that together with what the patient tells us, and we go, oh, hey, this is what must have happened. You know, this tissue normally, when I see someone with the knee replacement, this tissue isn't tight. Your tissue got tight. Something must have happened to cause that tissue trauma in the example that we're giving. And that traumatized tissue now needs extra help. And so then the reason I'm talking about physiology here is because pain medication may not change the physiology of that tissue, which is then why it stays painful.
Got it.
And that's where you need something that is usually different than a pill, for example. You need hands-on work. You need even prayer, for example. Or sometimes you need like an injection, but it has to go to the spot where the tissue is damaged and needs help.
Right. That's the prolotherapy you're referring to.
It can be prolotherapy, although it sometimes can just be an injection of saline. Like literally, it just needs, saline's like a lubricant.
Okay.
So it's tight. The tissue just needs help getting the fluid back into it to make it healthier.
Got it. Well, I get it. There's I think we need to up the level of expectation we have for the medical profession. I think there's a higher level that we can.
So I would say that, like, this is the way that my brain teases it out. Let's say, and again, I'm kind of making up numbers here, but let's say the average person takes 3 weeks to be off pain medication after a total knee replacement. Okay. If you hit 4 weeks, whatever, you might just be slightly outside of the average, nothing to worry about. At 5 or 6 weeks, the way that my brain wraps around it is there's something going on that we are not addressing clearly. And so you need a second, third, or fourth opinion until somebody says, hey, I think I have an idea of what's going on. Let's try this. And then that idea works. Right? So I think we need to augment what the medical community is doing with good logic and a knowledge of anatomy, and then we can help people to come off pain medicines faster. We can help improve the outcomes.
I agree. Okay. Well, I think we're going to cut this one. Look like you're dropping there a little bit.
I'm ready for a nap.
Yeah, let's do a hold on a second. We got to do our little donate promo thing, and then we'll wrap up the call. Our mission at the Comella Foundation is to relieve pain naturally using osteopathic healing principles. The Comella Foundation is recognized as a nonprofit 501c3 under the Internal Revenue Code. Your contributions are greatly appreciated. Please consider taking a moment and donating to the Comella Foundation to help us continue our important pain relieving work. Every little bit helps. Okay, there we are.
All right.
Anything
Awesome.
final words to wrap up other than goodbye?
If you haven't put up your Christmas tree already, it's starting to get late.
I hear you. Although if you're going with a live tree, now's a good time because it won't dry out by Christmas.
That's true. That's true. With the live tree, though, you can put sugar in the water. That helps.
Oh, did not know that.
Yeah.
Gosh, you're a wealth of knowledge. How does the sugar in the water help the artificial trees?
Well, it makes a mess all over the floor. And that turns sticky once it dries.
Good answer. Okay. Charlie, thank you so much. Appreciate you very much.
Yep.
And hope you feel better, and we'll see you next week.
Thank you, my friend.
Thank you. Bye-bye.
Bye.